I would like to welcome Executive Director Glenn Fuston. He is the Executive Director of the Governor's Office of Crime Prevention, Youth and Victim Services and was appointed to chair the Commission on Trauma-Informed Care. So I'd like to welcome Glenn to go ahead and get us started.
Great. Thank you very much, Christina. Really appreciate the introduction. And to say that I'm excited about this commission is a certain understatement. I am very excited to get things going here. I am very happy that our state is really moving forward on this work on trauma-informed care and specifically on ACEs and the important community of children, youth, and families in our older Marylanders is certainly very important to me. So I'm very excited. I wanted to, again, thank Christina for her opening, but also point out a couple other members of my staff that'll be here supporting us. Jessica Wheeler, who's our Deputy Director for Children and Youth, is with us, and so is Kelly Gorman, who will be supporting this group as well. There's a couple other members of my staff on that'll be presented and introduced later on, but the three of them will certainly be working to support this commission as we move forward. So I appreciate them. And I certainly appreciate all of you for being a part of this commission and, again, supporting the efforts to support the children, youth, and families in our older Marylanders with trauma-informed practices and creating this framework in Maryland. A critical aspect of the work that we'll focus on as a state are the policies that can do and or could reduce adverse childhood experiences, and also how to best implement care models informed by ACEs. We all understand that building a safer, healthier, and more prosperous Maryland starts with our children and youth, and I think that that's really where we're moving forward. We have 29 members that span the spectrum of both civil services, professional experience. The commission includes state government leaders, lawmakers, researchers, community-based organizations, representatives from the domestic violence, older adult and child abuse and neglect communities. So again, I just want to thank everybody for their time, their experience, and leadership that they're committing to this important issue. And I knew that through our collective efforts that we'll not only be able to complete the work that's designated as on this commission, which we'll hear about a little bit later as we go through that in detail, but we'll also be able to better serve all Marylanders as we move forward. The governor has been a staunch advocate for trauma-informed practices since he took office. I think many of you are aware that he launched the Handle with Care Maryland project in February of 2018. Maryland Handle with Care is an effective way for law enforcement to alert schools when a child at school has experienced a traumatic event. And it helps these children that have had these experiences receive care and support that they need from the schools. To date, we've launched Handle with Care in 19 of the 24 jurisdictions in Maryland, so we're really proud of that, and we've reached over 4,000 students since implementation. I'll note that Kelly Gorman is our project lead for that. She's been doing an amazing job with Handle with Care, so I wanted to thank her. Our office has also been working to address adverse childhood experiences in implementing trauma-informed responses. As you know, this year, the governor issued an executive order mandating that all state agencies serving children and youth work to address adverse childhood experiences. And since 2015, Governor Hogan has directed more than $192 million to agencies and organizations to support children's and youth through just our office. So we're really proud of that and the work that we've been able to move forward with the assistance of all of you. He also formed a working group in 2019 with the purpose of helping children and youth to navigating the judicial system after their lives were affected by crimes like domestic violence. We're also working to increase the number of accredited child advocacy centers across the state to ensure children who are experiencing abuse have access to trauma-informed services. So together with our partners at the Department of Human Services, the Maryland Children's Alliance, we've increased the number of accredited child advocacy centers in Maryland from only 10 in 2015 to 16 in 2019. So we're really happy about that. And again, wanted to thank you all for stepping into the gap to help serve the children of Maryland. And, you know, one of the best parts of my job is to serve on commissions like this, where we can collaborate with multiple disciplines, folks that may not always come together to work. But one of the things that I always am so happy to see in Maryland is that I think many times we're able to put any differences aside and come together and realize that we want to do what's best for our children, our youth, our families, and our older Marylanders. So I'm very excited to be on here. And with that, I'm going to go ahead and kick it off with our agenda. You'll see that we do have a pretty stacked agenda. I'm going to try to keep us pretty honest to the timing there. We figure that just as a general overview, that we would have Cameron Edsel from my office give us an overview of the bill. Then we're going to have a presentation on trauma and trauma-informed response to help us kind of level set and develop a definition for that so that we're all working from the same guidebook. And then discuss the goals, look at a timeline and meeting dates, and then we'll discuss some next steps and wrap up from there. So with that, I'm going to go ahead and turn it over to Cameron to give us an overview of House Bill 548, Chapter 722.
Thank you, Glenn. I appreciate the introduction. For those of you who do not know me, my name is Cameron Edsel. I'm the Legislative Affairs Manager for the Governor's Office of Crime Prevention, Youth and Victim Services. And I wanted to give a little bit of a brief overview of not just the House Bill that established the commission, but also the executive order that the governor had authored to promote the reduction of adverse childhood experiences in Maryland. One of the things that the governor's executive order did was that it made it a really big responsibility of the state to know the impact and development of children and youth, and highlighted the Center for Disease Control study that stated that childhood exposure to traumatic experiences increases the likelihood of physical or psychological illness later in life. And so because of that, it's the state's responsibility to promote a multidisciplinary collaboration and approach. And not only that, but an understanding of the impacts that adversity, toxic stress, and trauma can have on a child, and how the reduction and the mitigation of those experiences can serve to better help the child's growth and development. And so with Governor Hogan's executive order wanted to make this a priority, that state agencies work with each other, provide programs, provide data that are evidence-based in order to reduce these adverse childhood experiences. And so with that in mind, the commission was established to coordinate this statewide initiative to prioritize how the state can give such evidence-based trauma-informed delivery of state services that will affect, as Glenn was saying, children, youth, families, and older adults. As Glenn said, the commission has 29 members, and also the commission is tasked with establishing operating procedures, subcommittees, or work groups that consult experts who are not members of the commission to bring in that outside expert and advice on how we can establish the best trauma-informed care approach. Some of the roles of the commission, as outlined in the bill, is to identify state programs that are effective in impacting youth, families, and older adults, to develop a statewide strategy, as the bill says, to go towards what they call an organizational culture shift into a trauma response in state government. So making sure that the state is a leader and knowing what it's like to provide effective evidence-based practices. With these evidence-based practices in mind, the commission needs to establish metrics with the Maryland Department of Health to evaluate how the initiative is going, and also to coordinate with the Maryland Department of Health a formal or informal trauma-informed care training that they can give to members and those interested parties. Not only that, but disseminate info among agencies about best practices, right? Information sharing is a very important function in promoting understanding about how to implement this trauma-informed care approach. And not only that, but advise the governor in providing oversight of implementing these requirements, making sure that the governor and the governor's staff and General Assembly are informed of the status of this commission's work. And also, on or before June 30th every year, the commission has to submit a report that includes an assessment of the implementation of the trauma-informed care approach within each agency involved, the trauma responsiveness of each agency, and what recommendations the commission has regarding improvements to existing laws that relate to children, youth, families, and older adults. The bill goes on to list some of the terms defined. It defines trauma-informed care as stated in Maryland Health Code. That's Chapter 10, Section 701, and that defines mental health treatment as including an appreciation for the high prevalence of trauma experienced by individuals receiving mental health services, an understanding of the neurological, biological, psychological, and social effects of trauma and how that can have an impact on an individual, and then also an understanding of the environment, practices, and treatments that may need to be modified to address trauma issues. It defines children in the bill as people under the age of 14, and it defines older adults as people at least 60 years of age. And so I think one of the main highlights of this bill was, as you see on the screen, implementing what's called an ACEs Aware program. And that's the the responsibility of the Maryland Department of Health, Department of Human Services, the Maryland Healthcare Commission, and then this commission to coordinate and develop a process for implementing what's called an ACEs Aware program. This purpose of this program is to screen for adverse childhood experiences and toxic stress so that evidence-based practices to support individual and family health can be provided, but also the goal of reducing healthcare costs. And so as part of that coordinated response and framework for the ACEs Aware program, the commission is tasked with proposing a process to set up training, as mentioned earlier, and also accreditation for providers in the program when they implement this training. Also, the commission is tasked with exploring the possibility of third-party reimbursement, including the state medical assistance program for screenings that happen under this program. And then also there's another report to be submitted on or before October 1st each year, beginning in 2022. The commission needs to report its findings about the development and implementation of this ACEs Aware program to the governor and the General Assembly. And then finally, what I wanted to talk about was provisions in the bill related to required trainings for trauma-informed care. That relates to that last bullet point on your screen. The last section of the bill defines what it means by formal training as it relates to trauma-informed care. These trainings are defined as a didactic course or curriculum in trauma-informed care that is developed by the U.S. Department of Health or the Maryland Department of Health and is provided by the Maryland Department of Health or its designee in collaboration with the commission. So these trainings either have to be with the U.S. Department of Health and Human Services or the Maryland Department of Health. And that it requires that each member of the commission has to participate in at least one formal training each year. So each commission member doing one formal training each year. And then each agency head or director of the agency or secretary that is involved in the commission has to designate 2 staff members to participate in not only one training each year, but they have to collaborate with other agency designees in work sessions and other informal trainings that are organized by the Maryland Department of Health and serve as principal advisors to their agencies in providing relevant information about trauma-informed care. They also have to assess the agency and provide recommendations for maybe any further training or technical assistant needs as it relates to the agency's work with the commission and as a separate standalone responsibility of addressing trauma-informed care. And then they also have to make recommendations to their agency's director or agency head to make sure that the agency's policies in and of itself are aligned with a trauma-informed approach. The Maryland Department of Health will provide technical advisory and support to the agency staff to make sure that these duties that are being recommended and enacted are being carried out efficiently and effectively. So that's great that that technical advisory support is there. And then also, this is another requirement as a report or progress that on or before March 31st each year, the agency has to submit to the Commission a progress detailing how the agency is complying with the training requirements for these 2 staff members that are to be designated by the agency head. So there's a lot of moving parts going on in this bill, and I know that it's quite extensive. And so this memo that I'm referring to has been, I believe, sent to members of the commission. But also, if this is something that people may want to receive a copy on, please feel free to check with either myself or Kelly or Christina or Jessica Wheeler, and we'd be happy to field any of your questions or inquiries. So I just want to provide a little bit overview of the bill and kind of how this, outlines the roles of the commission and, the priority of the commission to develop best practices in relation to not only the ACEs Aware program, but the trainings that are required to make sure the state is a leader in trauma-informed care. And so with that, I thank you for your time.
Thank you very much, Cameron. Are there any questions directly of Cameron? If so, you can put them in the comments there. And obviously, we'll be following up with some more details on the specific goals and outcomes from this this bill as we go through time. So moving along, one of the things that we really thought would be good is to level set for the entire group on trauma and trauma-informed responses in general. And with that, we're very excited to have Frank Cross with us, who is the founder and CEO of the Cross Learning Group, to give us a presentation on this. Mr. Cross is a career child advocate who has served in the child care as a child care worker, working with child abuse investigations, children's home administration, consultant, professor, attorney, writer, and speaker. So prior to that, he served 18 years as an officer and executive with the Children's Guild Alliance, headquartered in Maryland. He's given presentations and workshops in 44 U.S. states, 6 foreign countries, and is generally known as an expert here. And we're really excited to have Mr. Cross here to give us a presentation. So with that, I'll turn it over to you, Frank.
Thank you. Good morning, everyone. Really excited to be here. I'm a member of the commission. I thank you for that warm introduction. I'm a member of the commission and wanted to share with you some ideas as I start out on the commission as a way of, as mentioned, giving a brief overview, but also generating some of our thinking around, for me, what I call opportunity imagined. The opportunity here provided by and through this commission, I couldn't be more excited about. So every project, right? An opportunity to learn, to figure out problems and challenges, and to invent and reinvent. And there are many opportunities, I think, with the commission. A couple that came to mind right away for me is the opportunity to create common unified language together. So you've heard in the introductions already both the terms trauma and adversity. What do those mean, and needing to define those clearly? The opportunity to build understanding, and understanding with every Marylander in all aspects of life and all our wonderful diversity, so that what we're sharing, what we're focused on here in trauma and adversity is accessible and usable and understandable. And then third, the opportunity to transform lives across Maryland, the what can we do aspect of what we'll be so dedicated to doing together. So starting out with that first one with common language, a potential objective that we might want to think about, at least I hope we do, is introducing a common unified definition for trauma and or adversity that we create together and that we can use across our state, that's rooted in research, but again, accessible to everyone. Will we use trauma? Will we use adversity? Will we use both? How do we define those terms? Because trauma has a lot of definitions. So I thought I'd just show you a couple from, very respectable sources, but just to set out how different and the variety of focus, right, that some definitions have. So this one from the Substance Abuse and Mental Health Services Administration talks about trauma as an event or series of events. When we look at childhood trauma, a wonderful resource many of you are familiar with, the National Child Traumatic Stress Network talks about children being overwhelmed, right? Their ability to cope with certain circumstances and situations because of exposure to events. When we look at the DSM from the American Psychiatric Association, we see traumatic stressors, again, defined as events that may cause serious injury, sexual violence, etc. But we also know, right, that there's a lot more things that might result in trauma. Here from the American Psychological Association, an emotional response. So
Right.
Note this one
Can I
doesn't.
interrupt you for a second? Your
Sure.
slides are not advancing. Nobody can see your slides.
Oh, well, yeah, that is problematic. So, okay, let me It came up on my screen.
We could see the slides, but we didn't see them advancing. We just saw the first screen and that's where it stayed.
Okay.
I believe, and I think they were shared with Christina, so we can probably bring those up on our end if that's helpful.
Christina, should we
See if
do
that
that?
works.
Yeah, Frank, I can do that for you.
Okay. Sounds like that would be better instead of me continuing to fumble with that PowerPoint. So thank you for pointing that out to me, first of all. Christina, let me know when you're ready.
Frank, were you not able to see the slides?
Yes, I could see them.
Okay.
So from my perspective, I was moving right along. So again, I appreciate being told they weren't advancing.
Okay. So just let me know what slide I should be on right now.
Okay. If you'd go to the next one. That's the one we were at least when I stopped. Yeah.
Frank, I'm also wondering, all I can see is like your notes and the page like where you would make edits to a slide, not your slideshow presentation. So I wonder if that's maybe the issue, if maybe there's a different screen or something.
Can folks see the screen now?
Yes, we can see it, but it's not in presentation mode, so we can see like speaker notes included.
Yeah, because on my screen, it is full screen, unfortunately.
So Christina, if you hit from current slide, what happens?
I'm from current slide right now.
Okay.
And it is full screen on my screen.
Okay.
So here, what I can do is
That'll work.
that?
Yeah, we'll go ahead and go with that so we don't take up any more time. Again, thank you all. I apologize for that. So it will get a little bit repetitive. I'll say next so Christina knows when to hit the next slide. But the last quote I wanted to show with you here is traumatic stress reactions, normal reactions to abnormal circumstances. What's my point? Really good resources, really good authorities, all with a little bit of a different focus. So one of the things that I think as a commission that we'll be working on is what are our common definitions? What are our common language? Next, please. And so inside, right, every problem like that lies an opportunity. And for me, I think the accessibility to the information is a key opportunity and a key focus. Next. So that second question, building understanding with all, really getting across the message of why trauma matters. Next. And so introducing, right, the adverse childhood experiences study and demonstrating how it impacts individuals, families, generations, and communities throughout our state. Next. And so the ACE study, I know many of you are familiar with, a couple of highlights from it. Next. So ACE, again, stands for Adverse Childhood Experience, not necessarily a trauma. Back to the first point about defining those terms. And go ahead, you're fine, Christina. Next. And so the ACE study, right, the original kind of foundational study confirms with scientific evidence adversity early in life increases physical, mental, and behavioral problems later in life. The first to make that really strong and really powerful connection. So while we talk about childhood adverse experiences, we're really talking about their impacts across the lifespan for all Marylanders. Next. And just wanted to point out here that since that original study, hundreds of studies have been done on ACEs. and conducted and published. Scores are currently being conducted, and they're being conducted all across the globe. So the ACE science is really substantial, it's rigorous, it's enduring, and it's worldwide. So that site on the bottom was about New Zealand, which just published their ACE study and showed the powerful connection between adverse experiences in childhood in New Zealand and the health and behavioral and social outcomes. Next, please. ACEs are common. Next, please. And so in the original ACE study, there were 10 ACEs that were looked at, and you can get an idea of what some of those were there. Kind of the point here is not every possible adversity was studied. It was an epidemiological study, just 10, but it'll give you a sense of which ones were there. Next, please. And when we say ACEs are common, we'll see only a third of the 17,000 respondents had no ACEs whatsoever. The vast majority had one or more ACEs, and in particular, 42% had 2 or more ACEs. Now, more locally, next please. In Maryland, based on the BRFIS data from 2018, we're looking at about 38% of Marylanders reporting no ACEs in that BRFIS data, 38 almost 39%, 1 to 2 ACEs, and almost a quarter of us in Maryland reported multiple ACEs, 3 or more. Next, please. And so ACEs are really highly related. So they tend to occur in clusters, and it's the cumulative impact that really, I know when I first saw the ACE study, really quite astounded me. It was astonishing, to be honest. In other words, the higher the ACE score, the more likely for those problems later in life. And the idea here was that ACE was capturing the consequences of traumatic stress neurodevelopmentally. Next, please. Now, in the ACE Interface, ACE Aware curriculum, we have this quick, but I think really helpful kind of infographic about that. So starting from the left, working from conception all the way through adulthood, a couple of pathways, let's imagine. And the bottom pathway, a pathway of safety, what we hope for all our children and what they have. And when predominantly you have an experience of safety in childhood, you develop, right, your brain adapts to that environment, and you develop skills with people, with processes, and with possibility, right, vision, future planning, imagination, right, goals, ideals, etc. And so consequently, when you reach adulthood, as you see in that third bubble on the right, when you reach adulthood, as long as the conditions that you're in, right, allow for the use of people skills, relationship skills at the level you develop, the understanding of processes and our future orientation, which we often have, you do very well in those environments. But there could be, right, another option, which you see on the top-hand side. What if there's danger? What if there's physical abuse, sexual abuse, any of the many different adversities that could occur? Well, you adapt also to that environment and that situation, but you adapt very differently. The literal structure, the architecture of your brain changes because your focus is on what many of you have heard before, fight, flight, or freeze. You develop the skills of survival in that environment. Consequently, when you move to adult functioning, right, you're well prepared to continue to survive if the environment remains dangerous, chaotic, unpredictable, harmful, etc. But the point of this slide is that both the top and the bottom are adaptations. The brain has adapted just like it's designed to do. It's adapted to its environmental circumstances. So we wouldn't be surprised, for example, if we took someone in the bottom pathway, right, that had the people, process, and possibility skills, and placed them in a very dangerous or chaotic situation, right? We would expect that there would be some struggle there. However, sometimes we continue to remain surprised that when we take someone from that top adaptation pathway and we place them in the bottom environment, that we have struggles also. But it's adaptation in both cases. Next, please. So one example, and only one example, would be a school environment. So if we have a child who has, right, been exposed to that dangerous or chaotic environment, and then we come across expectations from an environment on that bottom pathway, like school, that's very structured, that's very predictable, that's very safe, what might you expect? Next, please. And what we see developmentally, what we see in the differences of the brain really show up here. And certainly school is one of the places where the effects of adversity and trauma first show up. Because the expectations that you see on the right to sit still for extended periods of time related to your age, often something that is one of the first pieces of feedback, right, that we make or hear about students. Well, if you're from that pathway of danger and chaos and lack of safety, you're going to be very reluctant to sit still because of hypervigilance. What your brain has learned is I need to pay attention, because if I don't pay attention, I could get hurt, I could get surprised. Same thing with sustained attention, the ability to focus, to concentrate, right? It's going to be shorter for me because of the way my brain developed, because in my environment of development, a short attention span is a risk. It's a vulnerability. I may be reluctant to share and to cooperate with others because of scarcity or self-reliance. Self-reliance has been better for me than cooperation. And of course, we always want children to use their words in those environments to solve big feelings and big emotions, frustrations, etc. But the use of my words is not going to be my first choice because of fight, flight, or freeze. So we see this really predictable, right, situation where we have an environment on the right, but we have an adaptation from trauma and adversity on the left, and those two are going to clash. Next, please. And when that happens, what's common? What's common? Not always, and certainly there are fantastic exceptions, but what's common is those children get blamed and labeled and punished and separated, isolated, rejected for their adaptation, something that their brain is designed to do and supposed to do. But in many places, these remain very systemic responses. Next. And so Robert Anda and Laura Porter, who developed the curriculum for ACEs, say it this way: we have a collective choice. We can develop skills and accommodations that enable and contribute, that enable everyone, to contribute to the community, or we can continue that societal pattern of rejecting people when they have what? Normal, adaptive responses to childhood adversity. Next. So ACEs are also strong determinants of health and well-being. As the number of ACEs increases, increased likelihood, right, of high-risk behaviors, chronic physical and mental health conditions. Next. Frequently referred to as the dose-response relationship. This is from the original ACE study, and you can see very obviously and very clearly that as the number of ACEs go up, right, the vulnerability, the risk of these behavioral problems, these health problems, psychological, mental health issues, dramatically and astoundingly rises in lockstep. Next. So just a few, this isn't even a comprehensive list, but just a few of the types of health problems in adulthood that are impacted by those adverse experiences in childhood. And just imagining, in terms of imagining opportunity, just imagining if we could substantially decrease any one of these, let alone all of them, what an incredible transformation in our state, in the quality of your life, the decline in suffering, even the cost is pretty astounding to think about. Next. So in the United States, in 2019, 439,072 deaths, right, accounted for through that childhood adversity tracing. Next. And Anda and Porter, in their ACEs Aware curriculum, share what's called this oil slick diagram. And essentially what you see in the pie pieces there in the different colors are overall in the entire population, what the risk is for the particular issue, particular condition that you see to the right. Okay? The oil slick part, the black part, the darker part, and the percentage within it is the estimate of the amount of that condition that would decrease if we eliminated ACEs. And so the opportunity here really gets exciting, because just take, for example, suicide that you see there on the bottom right about the 6 o'clock, 5 and 6 o'clock position, 67% decrease in suicide by eliminating ACEs. I don't know what other intervention allows us that much opportunity to change the human condition. Next. So ACEs, preventing ACEs significantly improve human well-being, right? And also result in tremendous cost savings, savings that could be, right, reinvested in things around enrichment and development and growth, instead of having to respond to these consequences. Next. Estimated that in North America alone, the total health system cost ACEs $748 billion. Next. In Maryland, just two examples, just two adversity examples, child abuse and neglect, just those, and there obviously are many, many, many more, 1.5 billion each year. And just in those two areas, abuse and neglect, investing $1 in prevention saves $15 in long-term effects. So some really significant opportunities for cost savings also. Next, please. And there are, right, those of a more cynical bent who say that these things have always been there. You really can't make that big a difference. You really can't make that big a change. But a pessimist sees difficulty in every opportunity. An optimist sees opportunity in every difficulty. This is a complex and challenging area, but the opportunity is really incredible. Next, please. So finally, to finish up, what can we do next? This is what our commission's all about. So that's what we're going to be doing together. That's what I'm so excited about with this opportunity. Next. And the, I think, really exciting news is I've been, had the benefit of knowing about a lot of Maryland organizations and citizens that have already done really high quality, meaningful work on trauma and ACE awareness. In other words, we're not starting from zero, a tremendous and incredible amount of work already done, as well as work from other states. And I know in the course of our work together and our discussions, we'll hear about Tennessee and New Jersey, California, Wisconsin, Pennsylvania, Missouri, Delaware, and others who have had really exciting innovations and provide us models that we can look at and determine what we want to take and utilize from what they've already done. Next, please. So we can learn an awful lot from our Maryland pioneers, and I salute those pioneers, many of whom are on this call right now, for their work, as well as our fellow states. Next, please. So every moment is an organizing opportunity, and this one certainly is. Every one of us a potential advocate, and every minute a chance to change the world. And change the world can get used a lot as a term. This opportunity really is one of those. Imagine the opportunity.
Great.
Thank you.
Thank you very much, Frank, for the very informative talk and overview. Certainly appreciate that. And I know that many of you asked for copies of the presentation, and with Frank's permission, we'll certainly get that out to everybody. Very welcome to have you, or happy to have you on the commission as well, Frank. Your expertise will certainly blend well with everybody else on the commission. I do remind everybody to put questions into the chat box, and we'll ask Kelly or Christina to bring those questions out as we move throughout the meeting, and we'll go from there. So again, Frank, thank you very much for your presentation. I was also trying to think of a very creative way to pretend as if I had planned on doing introductions now, and that I did not forget to do them in the very beginning, but I can't think of that. So I was just too excited to get into the meat of this. So Jessica and the team have reminded me that we did not do introductions, so I apologize for that. So with that, I'm going to ask Kelly if you could lead us through introductions of the council members. If you could call on each of the members and give them an opportunity to introduce themselves.
Yes, absolutely. So for those that don't know me, my name is Kelly Gorman, and I am with the Governor's Office of Crime Prevention, Youth, and Victim Services. And you all have probably received more than one email from me at this point, and so now you can put a face to a name. And to make things easy for everyone, I'm just going to go through my list of members, and when I call your name, if you are here, please just give us a quick introduction. And so first, and I apologize if I mispronounce your name. I'm sorry, I'll do my best. But first I have Tara Doty.
Hi, everyone. I am here. I apologize. I'm the founder and lead consultant of Sage Wellness Group. We are a national consulting firm based in Baltimore that uses a mindfulness-based and trauma-informed approach to support organizations and communities in improving the lives of their staff and those communities that they serve. And I'm very excited to be here. Thank you very much.
Thank you. Next, I have Joyce Harrison.
Wow, that was quick. I wasn't expecting so quickly. Hi, I'm Joyce Harrison. I am a child psychiatrist. I'm based at Kennedy Krieger and on faculty at Johns Hopkins. And I'm proud to say I was in the first cohort of the ACE master trainers, and I've spent the last several years training medical professionals about the importance and the impact of ACEs. I'm so thrilled to be here. Thank you.
Thank you. And yes, this isn't alphabetical. I'm going through my member list, so that's why it's going to be all jumbled. Next, I have Fred Steiner.
Hi, I'm Fred Streeter. I'm a retired professor from the School of Social Work. Hi, Joyce and some other people. I currently work for the Mosaic Group, who works with substance abuse issues. My past work is I was one of the founders of the Family Center at Kennedy. Joyce also worked, and also the Family Connections and Trauma Family Connections through the University of Maryland School of Social Work, and some involvement in the National Child Traumatic Stress Network. I'm also interested in secondary traumatic stress, all of us as well. Think about that in our ACEs. So that's it. Thanks.
Thank you. Heather Chapman.
Good afternoon. I'm having some technical issues with sound. Good afternoon, everyone. Heather Chapman. I'm Vice President, United Way Neighborhood Zones. I'm happy to be here. Within our neighborhood zones, we have United Way Family Centers where we support expecting and parenting students, but really using a trauma responsive model with that. And then also school-based mental health supports for students who need that trauma responsive care. And so happy to be here. Thank you all.
Thank you. I have, Frank Cross, we heard a quick bio. Thank you. You guys all know who he is. Next, I have Matila Sakhwar-Jones.
Good morning. My name is Matila Sakhwar-Jones. I'm the Director of Community Engagement Services with the Family Tree. As a part of my role with the Family Tree, I manage a statewide ACE interface master trainer and presenter program. So we have over 200 master trainers and presenters across the state, and we've been able to disseminate ACE education to about 25,000 Maryland citizens since about 2017. So we're super excited to see this grow from a public education initiative on our end that's been a lot of community-based members to something that the state has been able to pick up and has been really been looking at as a part of a strategy toward ACE prevention and mitigation. So we're super excited to be here, and thank you so much.
Ulysses Archie.
Hi, my name is Ulysses Archie from the Baltimore Gift Economy. We were the community partners that came to the ACE Adverse Childhood Experience Training at the Family Tree, and thank you guys as part of the first cohort. And the Baltimore Gift Economy provides services by giving food and building relationships through giving food. And we also have a farm that we use trauma-informed practices with, and it's been working wonderfully. And I'm so grateful to be a part of this commission. Thank you so much for having me.
Thank you. I have Jessica Latorra.
Good morning. My name is Jessica Lortora. I am currently a community coordinator for the Frederick County Safe Babies Court Team Program and an employee of 0 to 3. So I also have had the opportunity to have a lot of colleagues on this call, so I'm super excited to be able to see faces I haven't seen in a while. I previously worked at University of Maryland's Tagi Mataresi Center for Infant Studies, so my main kind of expertise really is with infants and early childhood. Thank you for having me.
Thank you. Debbie Badwadi. I know I mispronounced your last name. I'm sorry.
That's fine. I'm Debbie Badawi. I'm a developmental behavioral pediatrician at University of Maryland. And I've worked with many folks on this commission as well in different capacities. I'm also the current president of the Maryland chapter of the American Academy of Pediatrics, and building resilience and helping families to prevent the outcomes that we have learned are associated with ACEs is something I'm very excited to be here to work on.
All right, and Inga James.
Hi, thank you. I'm Inga James. I'm the president and executive director of Hartley House in Frederick, which is a comprehensive program for survivors of domestic violence, sexual assault, human trafficking, and child abuse. I'm also on the board of the Maryland Network Against Domestic Violence, and I am the founder and chair of Trauma Responsive Frederick, which was created at the outset of COVID to provide linkages, advocacy, and education around COVID trauma and the collective trauma that we've all experienced. And so we're 50 members going strong and getting a lot of community support from our leadership and from our foundation. So it's going very well.
Thank you. Councilmember Zeke Cohen.
Hey, good morning. Good to see folks. Zeke Cohen, represent District 1 on the Baltimore City Council and chair of the city's Trauma-Informed Care Task Force, and was proud to sponsor legislation in our council to make Baltimore the first city in America to implement and legislate trauma-informed care throughout our city government. So really honored to be on this commission, and just great to be with you all. Thank you.
Thank you. Elizabeth Groff.
Hi, I'm Lisa Guroff. I am a councilwoman in the small town of Sykesville, Maryland. So representing the small towns, but professionally, I am a national trainer and consultant at the National Council for Mental Wellbeing on trauma-informed, resilience-oriented, and equitable practices. So really excited to bring all the work we're doing at the national level and with other states to my home state.
Thank you. And I'm looking on my list. Next, I have Delegate Riley.
Hi, thank you. Delegate Teresa Riley. I serve in the Maryland House of Delegates, and my district is 35B, which is Cecil and Harford County. I also serve on the HDO committee and was part of hearing this bill. It's a very important bill. Over the last several years, I've been very interested in trying to reduce our suicide rates and also increasing our school psychologists, which has been very difficult. And I don't know why, but anyway, I would love to see that happen in the Maryland General Assembly. And I'm very excited to be a part of this commission. So thank you.
Thank you. I have Secretary Beatty.
Hi there, I'm Secretary Carol Beatty. I am the Secretary for the Maryland Department of Disabilities. We are a member of the commission. Thank you. It's an honor to be here with all of the experts and all of the legislators that have been advocating for this, and the governor's staff and our administration who have been also advocating for this and moving it forward. Prior to me coming into the administration and being asked by Governor Hogan to serve in this capacity, I was for many, many years a nonprofit executive director in the community serving people with disabilities. And so this is an issue that's near and dear to my heart. Thank you.
Thank you. I have Delisa Worthy.
Good morning, everybody. My name is Delisa Worthy. I'm the Director of Early Childhood Services for the Behavioral Health Administration's CAIAS Unit, Child, Adolescent, and Young Adult Services Unit, as a part of the Maryland Department of Health. So excited to be here today. I was also part of the first cohort for the ACE Master Trainers, and really looking forward to our work together.
Thank you. Where am I? Okay, I have a designee for Secretary Padilla. Mike, I think you're on the call, right?
Yes, good morning, everyone. Thank you, Kelly. I'm Michael Demidenko. I am the State Director for Child Protection and Family Preservation at the Maryland Department of Human Services, Social Services Administration. Although I'm new to this role, I've worked in public child welfare over the last 25 years in 5 different Maryland jurisdictions and at the University of Maryland School of Social Work. I'm so pleased to be part of this commission and look forward to our work together. Thank you.
Thank you. Secretary Abed.
Good morning, everybody. Sam Abbott, Secretary for the Department of Juvenile Services. Pleasure to be part of this group, and I look forward to the training and continuing our education and implementation of trauma-informed care in our facilities and with our kids in the community.
Thank you. Superintendent Colonel Woodrow Jones.
Hey, good morning. Jerry Jones, Superintendent of the Maryland State Police. I'm very, very pleased to be part of this commission. I think given our profession and where we are in the world today, there's a lot of knowledge here that can be passed along to our troopers and law enforcement as a whole. And I look forward to moving forward towards that end. So pleasure to be here. Thank you.
Thank you. And I have Sylvia Lawson representing Superintendent, Chandri.
Yes, good morning, everyone. Sylvia Lawson, Deputy Superintendent for School Effectiveness here at the State Department of Education. Excited to be here and happy to be a part of this commission.
Thank you. And Claudia Remington.
Hi, I'm Claudia Remington. I'm the Executive Director of the Maryland State Council on Child Abuse and Neglect. We're an advisory council to the governor and the legislature on the prevention, detection, prosecution, and treatment of child abuse. I'm also a co-backbone of Maryland Essentials for Childhood, along with the Family Tree. Many of the folks on this commission are part of that. The project, ACE Interface Project, we hope to bring here, and we've been recommending for at least since 2012 that an executive order and legislation around the ACEs science, and we're really excited to be here and be part of this. Thanks to the governor and thanks to the legislators and Zeke Cohen, who had a lot to do with this. Thank you.
All right, thank you. And I have Christina Bethel.
Hi, everyone. It's great to be here. So I'm a professor at Johns Hopkins Bloomberg School of Public Health, and I lead an initiative that's actually been around since 1996 to really try to make sure that we have measures of child and family health and well-being, and then be able to report it out through research and data and influence policy. And so my work with ACEs started actually in 2001 when we tried to construct measures for the National Survey of Children's Health. And now we have a full set of data for all states around that, and also have led the work around a national agenda for addressing ACEs and promoting positive childhood experiences. So the whole turn toward PACEs and looking at the fact that while it's a higher risk, most people with ACEs don't go on to have the problems that we see. They just have a lot higher risk. And what can we learn about that? And how can we promote the positive that is within and between us right now while we change all the social structures? So just research, policy, and practice, and national agendas. And I work a lot with the Campaign for Trauma-Informed Policy and Practice, and I'm a close partner for with Nadine Burke-Harris in California with the ACEs Aware Initiative and the Roadmaps to Resilience report, and some other really nitty-gritty policies around how do we really have community-based responses affecting all different agencies, including policing and justice and schools. So I'm really happy to be here to support this really critical work and in Baltimore and in the state.
Thank you. And from my quick look at our attendance, I believe I got everyone who is here. If I missed you, please introduce yourself, especially if you are a designee of a senator, delegate, or a secretary, and I did not call that one. Now would be a great time to introduce yourself.
Hello, everyone. I'm Steve Youngblood. I'm a program manager in child welfare with Washington County Department of Social Services, and I was fortunate to be one of the first trained as a master trainer in the first master training class offered at the Family Tree. Since then, I've been doing our very best to train our frontline workers on ACEs and some of the psychiatric crises our young people go in to get them to understand it's often a trauma trigger and ways to mitigate that besides having to go to the emergency room, which further traumatizes our young people, right? So how can we become better informed on how to mitigate a psychiatric crisis to get a person back to baseline so we don't have to go the ultimate trauma route of another emergency room or psychiatric stay, 3-day stay. So I'm looking forward to continuing to partner and ways to get this information across to all people who are on the front lines that have to get the fortunate opportunity to work with this population on a day in and day out basis.
Great. Thank you. And with that, I believe that concludes introductions for all of our appointed members of the commission. So Christina, I will throw it back to you.
Thank you, Kelly. And I think I can speak for everyone that we are really excited to have all of this expertise and all of this energy here in the room. One of the things that we wanted to start to talk about a little bit is from Cameron's overview of the bill, and hopefully folks have had an opportunity to look at that bill as it was sent prior. There's a lot of work that we have to accomplish as a commission in the next couple in the next couple of months. So one of the things that we wanted to start to talk about was just some of the goals of the commission and how we want to move forward as a group to do this work and be able to make our recommendations and our report to the governor and the legislature in a timely fashion. So some of this discussion is going to be a little bit about logistics and how we kind of work and function as a group. And then we'll also have some opportunity for some discussion on just broader strategies. One of the first things that we wanted to talk about is that we recognize that since there is so much work that the commission has to do, that meeting as a commission as a whole, we're not going to be able to get all of that work done. So one of the things that us as staff are presenting to the commission for some discussion and some feedback is around creating committees. So this is opportunity for commission members and also experts and members of the public to participate and contribute to the work of the commission. So these were just kind of 3 large bucket ideas for some proposed committees, that we think might help to get the work done of the commission. So one of the large goals is developing the statewide strategy for implementing trauma-informed practices. So we thought it would be important to have a dedicated committee to help pull together that framework and the outline for that strategy. Another committee idea is focusing on the metrics and assessments. So again, that is something that the bill outlined, is that we need to identify how we're going to be measuring and assessing what a statewide framework looks like, what is creating a culture of trauma-informed responses in state agencies. And so what does that look like? As Frank noted, there are lots of other examples that have been utilized both in Maryland and in other states. And so this committee would look at what else is being used to have to create metrics and create assessment tools and what we can use here in Maryland to best meet our needs. And then also training. Training is a large component of the bill of ensuring that not just commission staff are trained, but also state agencies are trained. And we also hope that once there is the statewide training, it can be utilized not just with state agencies, but then also can be kind of that gold standard that can be utilized throughout the state. So also working with community-based organizations. And so it's really important to create that training. So that would be, again, the focus of that committee, looking at what other training has been utilized here in Maryland, what can we add to it from other states and in other jurisdictions. So I'm just going to take a moment just to pause. This is just kind of something that the staff are proposing to the commission to start the conversation. But I would love feedback from commissioners about, do these committees feel like the right committees to address this work? Are there more that we should add to it? And so I'm just going to open it up for feedback from commissioners. Secretary Abed?
Yeah, so just a recommendation perhaps to do a check-in with the Police and Correctional Training Commission. I know that we do some training. We do training for our staff in trauma-informed care, but there may be other agencies, local law enforcement, public safety, police, that are doing this training, and maybe we need to get a sort of assessment of where we're at on those things. And I see, Jerry, you got some comments as well?
Yeah, I'm deputy chair for the Police Training Commission. I'm certainly happy to go back to them and run across what they may have, as well as just explore opportunities moving forward as a profession and intermingling what we come up with as a commission into that realm. So I'm happy to take the lead on that if everybody is amenable to that.
Thank you, Secretary Abed and Colonel Woodrow. So I think we already are starting to plan some committee membership ideas. And I think that's also something that the committees would work on, of having an assessment and a scan of what training is already out there. What is that training doing? Are there things that might be missing in existing trainings that need to be added to? So I think those are all kind of the purview of the training committee. I did see Christina Bethel's hand up.
Yeah. Hi, Christina. I'm glad you just said what you said, because I think there's some common elements that are going to have to happen for each, including that environmental scan and checking our assumptions, bringing in hopefully a lot more information about children and families and what's happening now in Maryland. And, you know, I know that for metrics and assessment, which would make sense for me, it starts with what are our goals? And what are we, so there's no way to have these conversations without having a broader policy and vision conversation. So I didn't know if we wanted to have a broader conversation, really clear as a group, with maybe a smaller group thinking about it, setting up a starting point proposal for really what are the goals and the already known policy levers that we know we can turn quickly. And there's lots of ideas there, and that then each of the committees would have something to really anchor to across them, so we don't come out with 5 different ways of talking about the same thing. And also doing extra work, because the data work is going to be needed for everyone. And so just sort of a little bit of a matrix model maybe for handling this, and then giving a little more guidance to the committee so we are efficient.
Yeah, Christina, definitely agree. And so I think that's something we've been thinking about as we're looking at future meetings and how we utilize this space all together as a group. And so I think that big picture thinking, that creating of a larger vision and larger goals is an appropriate use of our time together. And then that will help to guide all of the work of the committee.
And just a small addendum, and to not be shy to leverage work that's already been done, like the work we've done in California, the work we've done nationally that other states are doing. There's a no shame in like looking at, you know, we're not going to necessarily come out with different pieces, and we can talk about that. Like, whether you want to focus more on PACEs, which brings in fully the positive and adverse childhood experiences into the realm to begin with, which is the new name for ACEs connection, or what have you. But there's a lot to draw on, and so just maybe creating that starting point. Sorry, and I'll stop now.
No, great. Thank you so much. So I saw Matila.
Since we want to maintain the spirit of trauma-informed care delivery, it would be fantastic if we could make perhaps a research and data aggregation group that could perhaps do needs assessment so that community members themselves also have input in the type of work that we're doing. I mean, it's fantastic that we invite the public to these meetings, but if we could have a systemic way to not only track perceived needs of the community and not just the needs that we know from research and just from being familiar with service delivery in the community, it would really be a truly participatory and thereby trauma-informed approach to doing this work on the state level.
Great. Thank you so much, Matila. I see Inga.
Yeah, thank you. Trauma-informed practices started out, as a therapeutic model, but it's grown really into a culture. And in order to become or practice trauma-informed practices, you have to have the cultural backing from. So there's norm changes that have to be made. And so I think that what we really need to add to this also is a technical assistance committee, because organizations are going to turn to us if we're creating this to try and figure out what they're supposed to do.
Great. Thank you so much, Inga. I see Claudia.
Yeah, I just wanted to reiterate what Christina Bethel said about having the strategy development first, the vision, and really bring in other states that have done this already so that we're not reinventing the wheel, but really can build upon what other states are doing and look at that carefully. I think the metrics and the training then follow after that. I mean, I don't think that you could, if we have people looking at metrics and assessment before we know what our goals and our direction are, and I think it would be very difficult to go back and undo metrics and training that maybe didn't follow what we were doing together as a strategy. Thank you.
All right, thank you. Thank you, Claudia. And I see Elizabeth.
So just echoing what I'm hearing my colleagues say, I completely agree. Broadening this, including SAMHSA's principles, understanding that resilience, as Dr. Bethel said, right, the importance of the protective factors and of resilience, not just focusing on the initial 10 ACEs, but really broadening to understand beyond those 10, there are significant things that we can address. I think we've seen in Maryland the impact of historical and intergenerational trauma. And, I think we can really, I know what's going on in some of the other states, and I think we can also lead in broadening the conversation to that cultural conversation, bringing in SAMHSA's principles and talking about, someone mentioned secondary traumatic stress and the moral injury that our workforce is struggling with. So I'm really excited to be here and glad to hear my colleagues also kind of echo that broader perspective, because I think we can take what people are doing, but across the country, but I think we have the opportunity to really add and broaden that conversation to something that's much more meaningful from where people have started.
Thank you so much, Elizabeth. Ulysses?
Thank you. I was thinking about, the training and how people have been getting the training, but then it doesn't really translate into the actual work that has to go into changing the culture around that. And so I'm not sure how we would approach that, because the training is great. When people have the information, they can pull from that information. However, it's just a training until you do something with it. And so I wanted to see how we could kind of zero in on that so that we can have some type of service, quality of service, care, and community engagement around this.
Thank you, Ulysses. Councilman Cohen?
Thank you. Just hoping that we can also uplift race-based trauma, given the moment we're going through as a state, as a country, and the reckoning that I think we're all having, just the importance of being honest and explicit about systemic inequality as we talk about trauma-informed care, I think is really, really, really important, and just owning some of our history and how we got here in order to frame how we move forward.
Thank you, Councilman. Inga? Inga, you're still on mute.
So sorry about that.
No
Who will
problem.
be identifying the agencies that we're strategizing for, that we're targeting?
So from my understanding, it is all state agencies.
Okay.
But we do have representatives of state agencies here on the commission. So it is not exclusively to the state agencies that are represented with staff on the commission, but it's the intention is for all state agencies to be a part of to receive training and because it's part of the system.
Great. Okay.
One thing I also wanted to note that with the proposed committees that we have, these are just based off of some of what's required in the bill, but we recognize that there are other components that help get us to these things. So I also want to say that this is not the ultimate list. We recognize that there might need to be smaller work groups that do some work that may not last through the whole life of the commission, but are helping us to get to the work. So hearing things around technical assistance, hearing around how do we engage with community members to help inform us in that work. And there are lots of ways I think that we can do that, to Matila's point, but also for just as a process thing, members of the public and individuals who are not commissioners can serve on committees. So our committees can also be expansive beyond just our commission membership. So we can access those other experts or those other community members or community organizations to engage and inform the work of the commission. And so there is a role for non-commission members to play in the work of the commission, but that's through the committee process and the ability to attend and observe meetings, but we do have to be clear that there are some roles strictly for commissioners versus non-commissioners and other members of the public.
Christina, thank you very much. And I know that we have Matila and Elizabeth that want to get comments in, so I certainly want to acknowledge them, but I also want to acknowledge where we want to move forward on the agenda as well. So I'll get those two comments in, but I do want to kind of keep everybody focused on, we all know that this issue is a huge, huge, huge issue. And we could go on and on about many different things that we want to do, and we certainly want that feedback, but we also want to make sure that we stay very focused too on achieving the goals that were set in front of us. So just be mindful of that as we kind of continue to dig through there. So with that, I think Elizabeth, you were first, and then we'll go to Matila, and then we'll move forward in the agenda.
Yeah, just to Ulysses' point on, training isn't going to get people there, and so as we get into that discussion, that's what we do daily, is long-term consulting to help organizations move that culture piece forward. So, anywhere that I can help in that discussion and kind of the models that are out there to support that, would be interested in helping.
Thank you so much, Elizabeth and Matila.
Thank you so much. And I do appreciate that there has to be some kind of procedures for folks to be able to provide input. I'm just thinking of folks who have experienced trauma, especially on a historic and institutional level. At times, they struggle with being able to appropriately redress certain issues, especially in forums like this. And also thinking of the folks that when we talk about these screening projects, especially as we get deeper into kind of trying to entrench trauma-informed care in some of these service deliveries provided by state institutions, we do have to think about that the people most directly affected by these things are the folks that are being traumatized. So, having that input, I think, is extremely important, especially if the state really wants to become trauma-informed.
I think it's an incredible point. I think you're 100% right on that. So thank you very much. Christina, I think the next component on the agenda is also yours. And kind of in the same theme of timeline and meeting dates. I'm sure that none of you have anything else that you're doing. So we were figuring that we could meet on a daily basis. No, kidding. Christina, go ahead.
So what we are proposing is, in light of all of the work that the commission needs to do in a very short period of time, we are proposing that the commission meets monthly, and that there would be opportunities when we do create whatever our committee structure or work group structure is, that they would meet outside. There would be additional meeting time outside of the full commission meeting. So what we are proposing is, this date seemed to work for a lot of folks. We have our committee membership. So what we are proposing is the third Thursday of every month, from 10 to 11:30 a.m. I know folks may not have their whole calendars up here with them, but just wanted to see if there's kind of general consensus that this time works for folks. So either if you want to raise, you can do your hand raise, you can wave if I can see your face. Is this a time that generally works for folks? And we recognize there might be a particular day that doesn't. Okay, I'm seeing there's some general consensus. So what we can go ahead and do is we will share calendar invites with all of the commissioners for these meeting dates and times, so that they are holds on your calendar. These meeting dates will also be posted on the commission's webpage, on the Governor's Office of Crime Prevention, Youth and Victim Services webpage. And then as we have the event registration and agenda information available, we will be uploading that to that same web page. So that can be both a resource for our commission members, but also for members of the public to access this meeting space. So those will be some of our follow-ups. And then also, as we begin to identify, and that leads me to my next slide with some of our next steps. I know we haven't completely finished our conversation around like committee structure and what should be the focuses of those committees, but I think we had a lot of really good ideas. And even though we might not be at the place to start those committees, I think it's really important to start to identify commission members who might be interested in different areas in order to contribute. And then also, as we move forward, beginning to identify committee chairs to help lead and guide the work of those committees. So I think we want to try and have our committee structure set as much as we can. So then once we have the larger vision of the commission laid out and our strategy, we already have that structure in place so that we can get to work. So we will follow up, the staff will follow up with some ways for folks to express interest in committees that we talked about, and also provide additional suggestions if there are other committees or work groups that you think would help to guide this work. And then if you are interested in being additionally involved and taking on additional leadership roles, if you would be interested in serving as a committee chair and helping to guide that work. And then I do see some hands raised real quick. Councilman Cohen?
Sorry, that was up for, I'm good with those Thursdays.
Oh, okay. All right. Thank you so much. And then finally, we talked about, and folks have talked about there's going to be need for additional learning and information sharing with commission members. So we have reached out to some of our partners for providing some suggested presenters and opportunities for additional learning for commissioners. But if there is information that you think would be important to share with the commission, either just as resource material to review outside of meetings, or to create space during commission meetings to present, please feel free to reach out to Kelly and myself with contact information and suggestions, so that we can ensure that we are uplifting work that's already happening, but also helping to provide context, framing, and information to help support the work of the commissioners. And so those are kind of the things that you can expect from the staff. Kelly has been recording this meeting, so we will be sharing the recording, and that will be posted on the webpage as well. So you can share that. We will also share meeting notes once they are completed, and we would ask folks to review them. And please, if you have any corrections or amendments, do not hesitate to let us know. We want to make sure that we are accurately representing the conversations that we are having here today as a group. So if there are any questions about next steps.
But just to jump in here a little bit for Christina. So I think what you'll see coming out of our staff, we will take the comments and the feedback that you gave us on the work groups, and then send something out to the group on some retooled work groups. Ask for those of you to sign up, and then we can nominate chairs. And obviously, we'll send out the calendar invites. I know that they may not be good for everybody, but they're going to be the best that we could do at this point, so we can talk about individual conflicts as we move forward, going from there. So, Sherry, was there questions there?
No, I forgot to put my hand down. I'm famous for that. I'm good.
All right, sounds great.
Thanks.
And Claudia,
Okay.
how about you? Is there a question there? I don't know where Sherry is, but I want to go there. Sounds like she's having fun.
I'm on lunch break with my kids at school.
That sounds amazing. That's where I want to be, with the kids. Claudia, I'm sorry. Did you have questions? You're on mute there.
I'm wondering about the Christina mentioned several times timeline, and we had a lot to do, and just wondering what those pressures are as far as, I think we just really want to make sure that we're grounded in the science, and that we're looking at what's out there before we just jump into some of the details before. I think it's just really important, and I wonder if there's a learning time that we can get to before jumping into decision making.
I certainly agree with you there. And I think one of the things that we'll do is maybe come up with a timeline specific, so we see that if we have hard deadlines, for example, the reports, that we can work back from those dates. But I think that the intention for most of the work groups that we talked about was really to first do a needs assessment to see what's out there now, what learning do we need to do, so that we're all on the same page to move it forward. So I believe that we're working on the same group. Well, being mindful of time, I'm very much inclined to keep us on track with the timing. You can see the contact information for Christina and Kelly. I'm very excited about this group. I know that everybody shares that level of excitement, and we want to jump right in. I think this was a great first meeting to set some guidelines. I could tell it was be successful. I think that out of 29 members, I think we had representation from all 29 members today, and not a single person spoke when muted during the introductions. And I think that shows that we are going to be a successful group. That is my new measure in post-COVID times. So I really appreciate everybody. I hope you all know that from our office, from anybody, if there's anything that you want to sit down and discuss with our team, with myself directly, please feel free to reach out. And thank you all for your time. And I look forward to our next meeting. Thanks, everybody.
Thank you, everyone, for attending. Our meeting is now done. We just have staff that are staying behind just to do some housekeeping things before we close out the virtual meeting. So thank you so much for joining us today.